Today, we are talking all things sleep with an expert doctor. Her name is Dr. Nishi Bhopal. She is a board certified physician in both psychiatry as well as sleep medicine. She's also the founder of Intrabalance Sleep Education for clinicians, and we're going to link her YouTube channel and all her practice information below in the description. So be sure to check that out. All right, I want to dive right in. Tell me about the basic stages of sleep and what a normal sleep cycle should look like.
So this is really important because even when I talk to clinicians, I do a lot of like speaking and education for clinicians, for physicians, therapists, and whatnot. And I think it's really important to understand these basics because patients will come to you with data, right? Like come to you with data from their Apple Watch, their Fitbit, their Aura Ring. So we need to have this grounding to help guide them. Okay, so what's the normal sleep stages or the sleep cycle? So I like to talk about this in terms of sleep architecture. So sleep architecture is essentially the skyline of our sleep. If you think about New York City has a distinct skyline, Vancouver, BC, which is where I'm from, has a distinct skyline. So our sleep has a distinct skyline as well. And so this refers to the different stages of sleep that we go through. If you look at a hypnogram, which you'll see if a patient has a sleep study, it'll give you the sleep stages and it will look like that skyline. So I'm going to talk about what it looks like in adults. So essentially, we've got two main categories of sleep stages. These are non-REM sleep and REM sleep, or rapid eye movement sleep. And then within non-REM sleep, we've got three stages, 1, 2, and 3, which go from progressively lighter and then to the deepest stage, which is stage 3, deep slow wave sleep. So these happen in certain proportions. Stage 1 sleep comprises about percent of our total sleep architecture as adults. Stage 2 sleep is about 50% of sleep architecture. Stage 3 is about 20%. And then stage REM is about 25%. So what's really interesting about these sleep stages is that they occur in about 80 to 120-minute cycles where we go through all of these stages. And we have about 4 to 5 sleep cycles per night. And the cycles alternate between the non-REM and REM stages. The other thing that's important to know is that we get different sleep stages in different proportions across the night. So what I mean by that is in the first half of the night, we tend to get more of that deep stage 3 slow wave sleep. And in the second half of the night, we get more REM sleep. So even just explaining that to patients is really important because it helps them understand why it's important to have a consistent sleep schedule. Because if you're going to bed at different times and waking up at different times, you're cutting off that sleep architecture. So if you're going to bed too late, you might be missing out on that deep restorative sleep that we get in the first half of the night. Or if you're waking up too early compared to your chronotype, then you might be cutting off some of that REM sleep that we get in the second half of the night.
Is there like a specific time that you would recommend people go to sleep and wake up in general?
It's such a great question. So it depends. It really depends on the person's individual chronotype. Some of us are more night owls, so you might have more of a delayed chronotype where maybe your natural sleep schedule is from like 11 p.m. to 7 or 8 a.m., whereas other people are more morning larks, so they might have an earlier schedule. They prefer to go to sleep at 9 p.m. and maybe they get up at like 10 p.m. to 6 a.m. range. So the short answer is it really depends on the person. So I encourage people to tune into yourself and identify what your individual chronotype is. And how you can figure that out is just ask yourself, okay, what would my sleep schedule be if I didn't have other social obligations, if I didn't have to go to work, or if you're working with patients, if you didn't have to go to work, if you didn't have to go to school, if you didn't have kids waking you up at 5 o'clock in the morning, what would your natural sleep schedule look like? For example, if you were on vacation. And then can you customize your lifestyle according to that? And I know that's like a pipe dream for a lot of people don't have that privilege to be able to do that. But just even understanding that is really important. And there are ways to shift your schedule a little bit, which we can talk about when we talk about melatonin. But so short answer again is like there's no one prescriptive sleep schedule that's good for everybody. It really depends on your personal chronotype.
That's so interesting. Getting back to the stages of sleep, another question I have after you've talked about that is that can you ever get to deep sleep without going through other stages? Like it always has to happen that way.
So generally, you're going to go from a transitional stage. So those stages 1 and 2 are considered well, stage 1 is our transitional stage from being awake to going into then those deeper stages of sleep. So like if you're going straight into slow wave sleep, and that could be a sign that there's something wrong, right? That could be a sign that you're really sleep deprived, or maybe you're sick, or something else is happening.
Oh, that's interesting. And then is the REM stage where we dream, or which is the dreaming phase of sleep?
So REM sleep is typically known as dream sleep. We do dream in other stages of sleep. However, when we think about like those complex, vivid dreams with storylines that you can relay, like you can tell your spouse, like, oh my God, I had the craziest dream last night and all these things happened. That's typically happening in REM sleep, which is our rapid eye movement sleep. And One of the physiological things that happens in REM sleep is the body becomes paralyzed, and that helps to avoid acting out those dreams, right? So if you're dreaming that you're playing tennis or you're dreaming that someone's chasing you, if you're not paralyzed, you could start flailing and acting out those dreams, and that's a safety problem. So the body becomes paralyzed during REM sleep to minimize those acting out behaviors. So that's where you can get other sleep disorders, right? Like REM behavior disorder, which is an issue where people don't become paralyzed. Now they're acting out their dreams. Another issue that happens in REM sleep is because of that paralysis, the airway is more susceptible to collapse. So you might see worsening symptoms of sleep apnea during REM sleep.
Have a crazy dream, wake up feeling exhausted. Is that just a general sign that I'm probably not getting great sleep, or does that happen with really crazy dreams and REM sleep?
It's an interesting question. So it could be because of so one thing that happens during REM sleep is, again, physiologically, it's actually more similar to wakefulness than it is to sleep. So in the other stages of sleep, in non-REM sleep, you get slowing of the heart rate, slowing of the respiratory rate, slowing of the EEG. But in REM sleep, physiology is really similar to that of being awake. So you get increased activity in the EEG, you get increased eye movement. So that's what's called rapid eye movement, increased heart rate, increased respiratory rate. So it could feel like you're almost in a state of hyperarousal, especially if you're having bad dreams. And then I would also look at, are there other things going on? Like, are you getting enough sleep on a regular basis? Are there other issues that could be underpinning that feeling of exhaustion or unrefreshing sleep? So I'm not just talking about you, but just generally for patients, you want to make sure they're not having periodic limb movements or sleep disordered breathing, or that they're not generally sleep deprived as well. So we want to look at all those factors.
So in the sleep deprivation category, obviously there is insomnia. So can you talk a little bit about what insomnia is and how you would diagnose it?
Sure. So insomnia is essentially defined as difficulty falling asleep or staying asleep when you're trying to sleep, right? So there's acute insomnia and chronic insomnia. The definition of chronic insomnia is difficulty falling asleep or staying asleep at least 3 nights a week for 3 months or longer. And not all acute insomnia is going to turn into chronic insomnia. So that's basically the criteria that we're looking for if you're trying to diagnose somebody with insomnia. You can even use scales like the Insomnia Severity Index to get a sense of what's going on with that person. But there's a really important caveat here, which is that insomnia isn't always insomnia. So what I mean by that is I'll have patients come to me who are referred by other psychiatrists or their PCPs who the patient's not responding to the conventional treatments for insomnia. And so they refer them to me to get a consult. And just in the past few weeks, I've uncovered sleep apnea in many of these patients, which can look like insomnia because it can cause issues with sleep maintenance. People are waking up throughout the night. They're waking up unrefreshed. They feel like they just can't stay asleep. It can also be a sign of a circadian rhythm issue, especially in teenagers and young adults, where it might look like sleep onset insomnia, but they just have a delayed body clock. So they try to go to bed at 10 or 11 p.m., but they can't fall asleep till 2 a.m. That might get misdiagnosed as sleep onset insomnia. And I've seen that happen. I've seen people be prescribed Ambien when actually they had this sleep onset delay. So that's a really important thing that I want people to just start to tune into, that want to understand what is causing that insomnia. But okay, let's say you've ruled that stuff out and you've determined the person does have insomnia. There are very effective treatments. And so I think sometimes with sleep issues or insomnia, it feels very murky to people. They're like, where do I start? Like, what do I do? I'm doing all the sleep hygiene stuff and it's not working. But there are specific ways and steps you can take to address the underlying causes.
And what are some of those ways in terms of the first line treatment for insomnia versus going down the line if something's not working?
So the first line treatment, gold standard treatment, is CBT-I, or cognitive behavioral therapy for insomnia. And it's incredibly effective. So it's the first line treatment recommended by the American Academy of Sleep Medicine, by the NIH consensus. And essentially what it is, it's addressing the perpetuating factors that keep a person stuck in that cycle of chronic insomnia. So there's basically this model called the 3P model, pushes the person into chronic insomnia. 3Ps are the predisposing factors. So this is factors that a person might have that just makes them more prone to having insomnia. So for example, maybe a history of trauma, right? So that's just like an unchangeable factor. The next is a precipitating factor. So that might be an acute stressor. Maybe they're going through a loss of a job or a death of a loved one or a divorce or something like this that might push them into acute insomnia. But it's the perpetuating factors, that's the third P, that keep them in that cycle of chronic insomnia. So these are the behaviors and cognitions that a person engages in to try to overcome their insomnia, but that actually make the issue worse. For example, they might spend too much time in bed. So I see this a lot with people who have insomnia. They're like, okay, I'm just going to go to bed extra early, or I'm going to stay in bed longer in the morning because I can get more sleep. But that actually creates more problems. It creates more of an association of being in bed with being awake. So now they have this conditioned arousal response. They might start Googling remedies on how to sleep better and like go down a rabbit hole of trying different things that just aren't working. So CBTI is largely focused on addressing those perpetuating factors, and it's incredibly effective when done the right way.
So what does CBTI actually entail? Like, what does that even mean?
So CBTI, so it's cognitive behavioral therapy for insomnia, and it is different from sleep hygiene. And I see that get confused a lot with sleep hygiene, even in the clinical community with other physicians, where they're like, well, my patient's doing all the right things. Like they're not using screens at night and they're trying to exercise during the day. They're minimizing their caffeine. And yes, those are all helpful things to do. But sleep hygiene, it's kind of like dental hygiene, right? So it's a way to keep your teeth healthy. But then if you have a cavity, dental hygiene is not enough to treat that. Like you're going to need to see a dentist and get a treatment plan. Sleep hygiene is like that. It's not enough to overcome chronic insomnia. And in fact, studies show that if you give your patients education on sleep hygiene when they have chronic insomnia, it does not help. So CBTI, what it does is it addresses the cognitions, so those unhelpful thoughts that might be playing into the insomnia. So, for example, someone who doesn't have chronic insomnia, if they have a bad night of sleep, they're like, whatever. Like, they don't even think about it. I'm like, okay, whatever. I had a horrible night's sleep and I'll just go to bed tonight, whatever. They don't even think about it. Someone who has insomnia, they have a bad night of sleep and they're like, oh my God, like tomorrow's gonna suck. I'm gonna have to, like, maybe I'll take my melatonin extra early. Maybe I'll take some magnesium. And they start Googling and they start getting really anxious about it. Oh my God, I'm gonna develop dementia later in life. So they start to have this like a lot of catastrophizing and anxiety around it. And they start putting more effort into trying to sleep. And this is the great paradox of sleep, that the harder you try, the more elusive it becomes. Yes, so CBTI addresses that, but there's other components too. So there's behavioral things like sleep efficiency training. So we really want to improve their sleep efficiency with less of a focus on sleep duration, but just making sure sleep is consolidated and better quality. And then there's relaxation aspects to it. So it's a very prescriptive protocol.
So you meet with a patient either virtually or in person, and then they go through like a 1 hour a week session for several months, or how does that protocol look?
That's such a great question. So I think what's really exciting is that now with technology, there's lots of different ways that CBTI can be administered. So traditionally, it's been done one-on-one once a week for about 8 weeks, anywhere usually from like 6 to 12, but about 8 weeks. And each session is like a class. So the patient is learning about sleep, how it works, and then they're addressing all of these different pieces. So you're giving them tools and they practice them. But now it can be done digitally, so people can do it virtually. Like I don't see patients in person anymore. I just do everything virtually. But it also can be done in a group setting. So a lot of hospitals will have CBTI groups that you could refer patients to. And those are nice sometimes because patients get that group support so they don't feel like they're alone, because sometimes with insomnia people feel like they're alone, like they're the only one awake at night, and that can be very isolating. So the group therapy can be very therapeutic for people. But now there's tons of apps, and many of these apps are like they've studied. There's one called Sleepia that was designed by Professor Colin Espy. He's one of the big names in the world of behavioral sleep medicine. And I believe it's now approved by the NHS in the UK. So that is something that you can even prescribe. I'll ask my patient, how do you want to do this? Like, do you want to do this one-on-one? I have a sleep coach in my practice, so they might work with my sleep coach. They want that one-on-one, like high touch support, or some of them just want to do it on their own with an app. Some of them prefer to do it in a group. So you can really just inquire with your patient about what like system or approach would work best for them.
I'm smirking a little bit over here because as you're talking, I'm literally identifying with all these things because I'm definitely someone who gets stressed out about falling asleep and waking up on time and making sure I'm not late and getting the kids to school and all this stuff. And I'm also someone who wakes up in the middle of the night without fail, but I rarely have trouble falling asleep. Like I pass out to the point of like just putting my child to sleep and I'll wake up in their bed at like 3 in the morning. And then of course I'm up until 5 a.m. And then I pass out again at 5 a.m. and then wake up like completely exhausted, like having felt like I didn't sleep all night. When you hear something like that, do you feel like that's like
people who have insomnia are at a higher risk of developing anxiety and depression? And also if people have been successfully treated for depression and then they have a bout of insomnia insomnia, then they're more likely to relapse into their symptoms of depression. So it is really important. I'm a psychiatrist, so like that's my bread and butter of what I do with patients. It's just making sure that they're getting good quality sleep. Because if you can do that, it has such a significant positive impact on their mental health. Okay, so to what you were describing, that situation, I would just look at, are there some tweaks you can make with your evening routine so that you're not falling asleep in your kid's bed when you're snuggling with them at night, and then now you've fallen asleep until 3 o'clock in the morning and you get up, because that time, that 2 a.m. awakening, it's normal to actually have these awakenings through the night. I think a lot of people are under this impression that once you fall asleep, you should be out cold until the next morning. And that is just not how sleep works. And maybe when you're younger, like I remember when I was in my 20s, like I'd just be out. Like I would have no awareness of anything going on around me until the next morning. Now that's not the case. I do have these nighttime awakenings, but those are normal. They become problematic though if you have trouble getting back to sleep, or sometimes they could be a sign of something else going on that's disrupting your sleep. So it could be like hypoglycemia, it could be sleep apnea, it could be other sleep disorder like periodic limb movements and so on, perimenopause, menopause, those types of things. So anyway, so what I would suggest is, can you make some tweaks so that like you're intentional about leaving your kid's room so you can go to your bed, you can sleep in your bed comfortably, and then have a plan of what you can do if you do wake up at 3 a.m. and you find it hard to get back to sleep. So you want to have like an idea of like things that might be contributing to those wake ups and then what you can do to address them.
And when you do have a middle of the night awakening, right? Because I'm sure many people watching this are going to say, I totally wake up in the middle of the night. What's like a normal amount of time to fall back asleep? Like, is it 5 minutes? Is it 10 minutes? Like, I don't think it's 30 minutes. So, like, what is even acceptable?
Really good question. So generally about 20 minutes is what's considered normal. So like what happens is a lot of times we'll have these wake ups and we're not even aware of them. Like you'll see this on a sleep study where people will have these, like they almost call it like coming up to the surface. Like you're in deep sleep, you come up to the surface and then you may not be aware of it and you go back to sleep. Sometimes you are aware and then you're awake for 10 to 20 minutes, and that's okay. Like if you have to get up and use the bathroom, or you're just awake, that's okay. But it's what you do in those 10 or 20 minutes that may affect your ability to fall back asleep. Now, that's not to say it's the person's fault, because sometimes there is some other medical hormonal thing or sleep disordered breathing or something else that needs to be addressed. But the most important thing is just to recognize like, oh, I'm awake, and that's neutral. It's not bad, right? So like the moment you start thinking it's, oh my God, like I'm awake, it's 3 a.m., I have to get up, I only have 3 more hours to fall asleep. And then, oh, tomorrow I have this big meeting. And then and the mind starts going. And then that just makes it harder to get back to sleep.
So, what are some of the things that you should do or shouldn't do during that time if you happen to actually wake up and you're awake for 10, 15 minutes?
So, a few things. One is if you do have to use the bathroom, try to keep any light exposure to a minimum. So, I recommend having a little night light or having a dimmer switch on your lights if you can, so that you're not like turning the light on, you're getting a full blast of light, because that's going to wake you up. So, minimizing light exposure. It's not the time to go on your phone, like look at your schedule or like start checking email or doing any of that stuff. So, keep that aside. Some people, so some of my patients, they're okay with just laying there and doing a breathing practice or a relaxation practice. Maybe there is a use for the phone if you're going to listen to a guided meditation or listen to those bedtime stories that are boring. That's okay, but you don't want to do anything too interactive. The CBT-I recommendation for this is called stimulus control. And so what they actually recommend is to get out of bed. So this is for people who are laying there and you're starting to get frustrated, or you're getting into that cycle of like, oh my God, am I going to fall back asleep? I've got a big day tomorrow. That's when you want to get out of bed and maybe go to your couch, get a blanket, look at a magazine, or do something like that that's relaxing. Not the time to start folding laundry or doing your ironing or unloading the dishwasher, those kinds of things. Nothing too active. But if you're not feeling frustrated, like this is what I do to recommend this to my patients, is like you can lay there and like I really like to just enjoy the quiet time. Like, oh, it's so quiet, nobody's bothering me, my bed's so comfortable, like pull up my covers and make it an enjoyable thing, actually. And the paradox of that is that the more you can relax into that, the more likely you are to fall asleep again, even though you're not trying to do that.
Well, I'm doing all the things wrong because not only do I have to go to the bathroom at night, I use the light on my phone. So I'm on my phone immediately with the light, walking around my house. So yes, I definitely need to change some behaviors. I want to talk a little bit about some supplements because we see this stuff all over the place. And I'm sure there's a lot of patients who are wondering what's actually useful, what's not useful. Is this all BS? So first thing is melatonin. The one thing that I saw when I was buying melatonin was I saw this extended release. And then I posted on one of our physician groups. We are all on these like physician Facebook groups. And I got like a barrage of messages that were like, that is not like there's no such thing as extended release melatonin. So what is your opinion on melatonin in general and dosing, and when do you take it, and is extended release melatonin a thing or no?
Okay, that's so interesting. I'm surprised people said it's not a thing because it is a thing, extended releases.
Okay.
And so I'll talk about that in a second. Okay, melatonin, I think of as a body clock regulator. So the brain produces melatonin in an environment of darkness, and that's one of the things that helps us go to sleep. So it really it regulates the sleep-wake cycle. So I don't think of it as like a sleep aid. It's not something I recommend to people. If you have chronic insomnia, it's not recommended to take melatonin to try to sleep. However, it is indicated for certain conditions. So the American Academy of Sleep Medicine has outlined different indications for use of melatonin, and it's generally used for circadian rhythm disorders, things like delayed sleep phase syndrome, advanced sleep phase syndrome, shift work, jet lag. It's also indicated in children with neurological issues like ADHD, autism, other neurological issues. And there is also some research supporting its use in adults over the age of 55 because of potential reduction in endogenous secretion of melatonin. It might be surprising to people if your audience is mostly in the US, it may be surprising to US audiences that melatonin is not available over the counter in many other countries. In a lot of other countries, it is considered a hormone and it's available by prescription only. So in the UK, Australia, Japan, EU, other regions, it's a prescription and it's required to be monitored every 6 months. And there is a form of melatonin called circadin that's available in the UK and Australia that's extended release 2 milligrams, indicated for adults over the age of 55 for sleep support. There's also some research looking into its use in menopause in doses of about 3 milligrams for menopause, again, because of changes in melatonin secretion around that time of life. So there are specific uses for it. How I use it in my practice is as a sleep support to help regulate the circadian rhythm, because I do see this with patients who have anxiety and depression and sleep issues. Sometimes they just have their body clock is a little bit all over the place, like it's not that regulated. It may be drifting to the later side, or they might just have an irregular sleep schedule. So I'll use melatonin and light to provide anchors for their body clock while we work on other things. And I'm not generally recommending it long term unless the patient is on a melatonin depleting drug. So they might be on like a beta blocker or something like fluoxetine, which can inhibit the natural secretion of melatonin. So in those cases, we might be using it as a supplement. So yes, the short answer is there are ways to use melatonin strategically, but it's actually not recommended for chronic insomnia.
Hi, everyone. If you've enjoyed this interview thus far, be sure to hit the like and subscribe button below. It not only helps the channel, but helps out all the people that we interview. Thanks for watching. That's so interesting. I think one of the issues also with the US melatonin is that because it's a supplement, it's not as regulated. So each supplement that you get, like, is a different brand. You could have different reactions with different brands, right?
I'm so glad you brought that up because this is such an important point. There was a study in the Journal of Clinical Sleep Medicine in 2017 and then another research letter in JAMA in 2023 looking at this. And so in both of these, researchers ordered over the counter, like they looked at over the counter melatonin supplements to see, do they actually have melatonin in them, or like do they contain what they say they do? And I won't go into the details of what they found, but the summary of it is that like most of them didn't actually contain the amounts of melatonin that they said. So some of them contained like hundreds of times more. Some of them contained no melatonin and had CBD that wasn't listed. So quality is really important because supplements are regulated differently by the FDA in the US. I recommend using third-party tested brand. And in my practice, I use a platform called FullScript. So that's for professional grade supplements. And so there's a few brands that I use. Even personally, if I'm using melatonin, there's just a few ones that I like to use. I actually have a free melatonin brand guide download for any clinicians who are interested in knowing what brands are reputable. But one of the things that I hear a lot from patients is I took melatonin and it didn't work, or it gave me horrible vivid dreams, or I felt super groggy the next day. And what I'll tell them is that, well, one, it could be because it was a poor quality supplement, or it could have been the wrong dose or the wrong indication. So those are the three things that I like to look at: dosing, indication, and then supplement quality to determine like if melatonin is going to work for that person.
So you had mentioned that you have a downloadable asset for physicians, but for patients that are watching who want to get a solid supplement recommendation, do you have something available on your website where patients can go to look at different supplements?
Yes. So through my FullScript account, people can set up a consumer account, and then you can access my supplement shop under my brand IntraBalance. So in there, I've curated my own catalog of preferred supplements for different indications, including my preferred melatonin supplements. So people can go on there. So you don't need a prescription. You can just go on there and you can see what's available and then order it, just like Amazon, but through FullScript.
Awesome. Now, on the same line of this conversation, you had mentioned CBD. Is there any evidence to show that CBD is helpful for either falling asleep or staying asleep?
So this is also, it's a really interesting question because it's an active area of research. Like medical understanding hasn't been fully developed yet. So I'm keeping an eye on this space to see as new information comes out, like what are we learning? So CBD has been shown to be effective for sleep. THC, so THC is the aspect of cannabis that has psychoactive effects and that can have mood altering effects. So CBD does not have those effects. THC is shown to disrupt sleep architecture, but CBD is actually shown to be more favorable for sleep compared to CBD, to THC rather. So there is some evidence suggesting that CBD can improve sleep quality and reduce sleep disturbances. There was one study looking at 28 healthy adults, and they were given 50 milligrams of CBD over the course of 8 weeks. And what they found was that there were significant improvements in sleep quality that was self-reported. So they weren't doing sleep studies, but they had them do sleep questionnaires, and they did report improvements in their sleep. There was another study looking at 25 adults with insomnia, and they did find that. So overall, it's one of these areas that we're learning more about. Sometimes patients will ask me, like, what do you recommend? Should I take CBD for sleep? And my answer is like, I don't know, actually. I feel like I don't know enough about it. I don't know what the indications are. There's these couple small studies I just mentioned, but what are the indications? What are the strains? Who's it going to work for? What are the long-term implications? I'm not really sure. So it's not something that I'm recommending at this point in time.
And I think it's probably the same issue with supplements is that, again, it's not, if it hasn't gone through like a rigorous clinical trial, then you're not really sure what exactly is in a gummy that you might take or a beverage that you might sip on. So it's going to be an interesting landscape as more people start using CBD and THC and it's been decriminalized and it's being used more widely. So hopefully they can actually run some more studies and get us some more data as to what works so people aren't trying different things and getting frustrated. Another supplement for sleep that I definitely want to talk about is magnesium. I was recommended to take this during my pregnancy. I was having a lot of trouble sleeping and pooping and all these other issues. But what is the form of magnesium that is recommended for sleep? And does it actually have evidence to show that it is effective?
Okay, so magnesium is all over the place, right? Like I'm seeing it all over social media. I'm seeing these influencers who have their own sleep supplement protocols that have magnesium in them. So I get asked about this all the time. And what might be surprising for people to hear is that the data on magnesium for sleep is actually pretty limited. There isn't a lot of good data supporting its use in sleep. However, that doesn't mean that I don't recommend it. In fact, I have most of my patients on some form of magnesium. I take it myself as well. So I have a pretty low threshold for recommending it. There are some small studies showing that it can help older adults with insomnia. But again, limited data, but it's thought to work through mediating GABA, which is a calming and inhibitory neurotransmitter, but it's involved in over like 300 different enzymatic reactions in the body. So it's a really critical nutrient. So in terms of the form of it, so it's helpful for people who have, like you mentioned, like constipation, or people who have muscle tension, people who have anxiety, people who have like muscle cramps, those types of things. Even patients who are on like medications that could potentially inhibit the absorption of magnesium, so things like proton pump inhibitors, diuretics, and things like that. So that's like the vast majority of people, at least the vast majority of people that I work with. So for people who have constipation, then they can consider magnesium citrate, which has laxative effects. But if someone is prone to diarrhea, loose stools, or GI upset, then I prefer magnesium glycinate. And magnesium glycinate is usually more neutral for the GI tract. So that's a form that I take, and a lot of my patients take that as well. Magnesium threonate is another one that some of my patients like taking, especially if they have ADHD. There's some research supporting that it might be more helpful for that. But for most people, I think magnesium glycinate is a good form. And the caveat here is I don't want people taking it with the expectation that it's going to help them sleep, right? So you don't want to be taking it and going like, okay, I took my magnesium, I'm going to sleep well tonight. It's not like that. It's working in the background as a critical nutrient to give you some support. The other thing that I like, though, semi-related to this, is Epsom salt baths. So this is one of the natural remedies that I do recommend to people for sleep, for anxiety, for muscle tension. Epsom salts are essentially magnesium sulfate, and you can absorb some of that magnesium through the skin. And so taking an Epsom salt bath, it's really good for just relaxing your muscles at the end of a busy day, or if you had a hard workout. It's really calming. It helps to reduce anxiety. You can turn the lights down, make it like, I find that some of my patients, they just feel like they sleep so well after that because it's part of that wind down routine. So that's just another thing to consider.
In terms of other natural remedies besides the bath, what are some other things that people can do during the day to really just make sure that when they sleep, they're giving themselves the best shot at having good sleep?
Excellent question. So good sleep really starts during the day. What you do first thing in the morning is going to set you up for good sleep the next night. So a few things that I recommend. One is to maintain as consistent a wake time as possible. And again, I know it's not the case, it's not possible for everyone. Like my brother's a neonatologist, he works, his schedule's all over the place. But if you can maintain a consistent wake up time within an hour of waking up, you can go outside and do that. That's ideal. Other things that are helpful are to do a digital detox. And I do recommend doing this like half a day a week, one day a week, where you just put all your screens away. We're all so tethered to our devices. We're on all the time, always connected. Like a Sunday, like just put all your devices away and go do analog things, right? Like go spend time in nature, or what have you, spend time with your family. Another thing you can do daily for this digital detox is a strategy called the bookend strategy. And I really like this too. So all you do is an hour after you wake up and an hour before you go to bed, no phones. So no work, no stimulation. And it's amazing. Like if you just don't get on your phone or your laptop or what have you, an hour after you wake up, it's amazing to see how much time you have in the morning. Like, I've been doing this. I'm like, oh my God, like all this time that I didn't even realize that I had before when I was like just going into my email and doing stuff. So I really like that. Other techniques that are helpful are to do breathing practices throughout the day. And so I recommend this to my patients who are maybe on Zoom all day. So after every meeting, do a few deep breaths. See if you can go outside, go for a walk for just a few minutes midday. Get bright light. Most of us have a deficiency of bright light during the day. So going outdoors, getting that bright light, keeping it dark in the evening. Exercise, of course, is great too. And then I really like yoga nidra, which is a form of non-sleep deep rest from the yogic tradition. But there's actually studies showing that it's very effective to promote relaxation. It reduces negative affect, reduces anxiety, pain. It's valuable for people with sleep issues. And that's something that you can do. You can just look up guided meditation for yoga nidra. And actually the sleep coach in my practice, she works with a lot of apps and she does guided meditations for them. So her name is Lauren Ziegler. So you can look her up and you can find her yoga nidra audio files. So those are some simple things that people can do.
Another question, which I already know the answer to pretty much, is I know alcohol messes up your sleep, but if you are going to choose to drink alcohol, when can you drink it? Like a few hours before sleep? Like I know no alcohol is the best situation, but what is an acceptable situation?
So I think the first thing is just to understand how it affects you. I know that for me, it actually doesn't matter personally what time I drink it. Like if I have a glass of wine right before bed or if I have it a few hours before, I just know I'm not going to sleep as well that night. So that's the first thing. I just recommend people to just tune into yourself and recognize how it's impacting you and how it might also affect your energy levels the next day. How alcohol affects sleep is that initially it's sedating, right? So people will tell me like, but I feel like I fall asleep so much easier after I have a drink. And yes, it is sedating. So it reduces sleep onset latency, which is the time to fall asleep. However, in the second half of the night, you see a lot more sleep disruptions. You get more awakenings and you get a reduction in REM sleep, the rapid eye movement sleep. And then overall, you get a decrease in sleep efficiency, which is essentially how much time you're asleep in the bed. And those effects are dose dependent, right? So like the more drinks you have, then the more of an impact it's going to have on your sleep. So again, it really depends on the person. Everyone metabolizes it differently. So generally a few hours before bed, like maybe closer to dinner time might be better, but just pay attention and see how it impacts you.
And what about something like Xanax or a relaxing medication to help you sleep?
The way that I think about medications for sleep, whether it's a benzodiazepine, Z drug or Z drug, or something that's more off-label like trazodone. There's other classes that are newer like orexin antagonists and things like this. Think about using them short term and using them at the lowest dose for the minimal amount of time needed. And then to even have a plan to go off the medication before you even start the medication. So if I'm prescribing a medication like that to a patient, we're going to talk about their plan to come off of it before they even begin taking it. Because these drugs are not designed for long-term use, especially the benzodiazepines like Xanax. They can be cause dependency. People can have withdrawal symptoms. They're using them regularly. You can even get rebound insomnia. So if someone stops taking it, now the insomnia is worse. So they do have a role, like you can use them short term for those acute stressors. But I just don't want people to get into a habit of, now I need this to sleep. And then now they have chronic insomnia because there's a psychological aspect to it. There's a physiological aspect. So it's not that I'm anti-medications, but using them judiciously is what I would recommend.
And then obviously you have to be careful if you're also going to go out for dinner and have a drink and make sure that you're not mixing substances and being careful about all that stuff.
Exactly.
So what about sleeping too much? So I know that we should be getting obviously good sleep. And what is considered sleeping too much?
So most adults are recommended to get between 7 to 9 hours of sleep on average. So sleeping too much is considered more than 9 hours per night. However, I don't want people to just take these numbers at face value and go like, oh my God, I sleep 9 hours a night or 9.5 hours. If that's your baseline sleep need, that's okay. So, however, if you're experiencing excessive daytime sleepiness or like there's other things going on that's causing you to sleep more, that's where it can start to be problematic. Because we do know that these longer sleep times can be associated with adverse health outcomes, like an increased risk of cognitive decline and dementia, increased risk of sleep disordered breathing. Could this be narcolepsy or idiopathic hypersomnia? And I see that a lot in the psychiatric clinic where patients might be diagnosed with depression and maybe they actually had narcolepsy, which can look like depression. It takes people like more than a decade to get a diagnosis of narcolepsy. So we want to be thinking about things like that. Or is this a mental health issue? Are they experiencing depression or anxiety? Is there a chronic illness, heart disease? Is there chronic pain that might be contributing to these long sleep times? Are they on meds that are sedating or making them drowsy or have fatigue? And then are there lifestyle factors? So excessive alcohol use, excessive marijuana use, sedentary lifestyle, lack of physical activity, dietary aspects. So we want to be like looking under the hood to see what else might be going on.
What about napping? Like, is napping a good thing, a bad thing, neutral thing?
So I'm a huge fan of naps. I love naps. And there's actually quite a bit of research on naps, and it's really interesting. And even large companies, so like NASA, Google, Huffington Post, Ben and Jerry's even, they all have nap rooms in their corporate offices, not because like they're so kind and they want their employees to rest, but they know that when people take these short power naps, they actually have increased productivity. So it has a direct impact on their bottom line as businesses. So short naps can be incredibly restorative. And when I say short nap, like 10 to 20 minutes, not too late in the day, like usually before 3 p.m., that afternoon dip that we get the circadian dip, and other cultures might have a siesta built in. Those naps can be very effective. However, it's not recommended to be taking long naps. So if someone is needing, I have patients who tell me like, well, if I take a nap, I'm going to fall asleep for like 2 hours. Okay, well, that probably means you're sleep deprived at baseline. So let's get you on a better sleep schedule. So like once you take a nap, it's kind of like having a snack, right? So if you take too long of a nap, it's like having a large snack before dinner. So you're just not going to be hungry for sleep when you go to bed, right? So paying attention to that. Again, the caveat here is that if you're not well, if you're recovering from surgery, maybe you have COVID. I've been sick lately. You might hear it in my voice. So like when I had this upper respiratory thing, like I needed to nap. So if you're recovering from an illness and if you take those hours long naps during the day, that's okay. That's different. But day to day, short power nap, not too late in the day before 3 p.m. can be really helpful. And there is a strategy called a calf nap or a nappuccino, where if you have a little bit of caffeine before you take your nap, it takes about 20 minutes for that caffeine to kick in. So that can give you a little boost when you wake up.
Oh, that's so interesting. Now, my question is, for someone who has trouble sleeping, like I do, how do you fall asleep for that nap? Because I do feel that tiredness and I'm like, oh, I wish I could nap. And then I look at my husband, I'm like so jealous that he just like can fall asleep and just nap for 15 minutes or 20 minutes. And I cannot do that.
So you may not fall asleep during that nap. Like even just lying down and closing your eyes can be restful. And that's a time where you could consider doing the yoga nidra meditation, that non-sleep deep rest. So you're actually not falling asleep, but you're getting into a deep state of relaxation, which is then really restorative. So you might even come out of that feeling like you had a nap, even if you didn't sleep. However, so if you are struggling with insomnia, then it's not recommended to take a nap. Okay, so I'm talking about people who are not struggling with sleep and they just want to optimize a little bit or figure out a good schedule for them. And those little naps are okay. But for anyone with insomnia, it is not recommended to take naps during the day because it will make it harder to fall asleep and stay asleep at night.
This was super helpful. Thanks so much for spending your time here. What are some of the ways that patients can find you or your practice if they're interested in learning more?
Well, thanks so much for having me. I love talking all things sleep, so I'm really delighted that you had me on, and this was so much fun. So if people want to work with me or my team, you can find us at Pacific Integrative Psychiatry. So pacificintegrativepsych.com is our website. And then if you go to at Pacific Integrative Psych, you can follow us on Instagram, or you can look up my name on LinkedIn and connect with me there. And I see patients across the state of California. Then I have a sleep coach who's able to see patients globally.
Awesome. Thanks so much.